you doing? Um, yes, it's always a bit unusual giving these lectures over Zoom because I usually give these interactively with seeing the audience and things like that. So we'll be back there one day and hopefully soon. So I hope all of you are safe. And we've got a bit of an interesting topic of occlusion demystified in implant dentistry this evening. And I hope to make it kind of a little bit of fun, a bit interactive, make you guys think a little bit about your cases and take a slightly different approach than a very dry subject normally, or something that's not quite understood very well by many of us, I suppose, for a long time. So what I'm going to start doing is actually going to share my screen now, and we're going to start the lecture. Okay, so, and hope everyone can see that. So occlusion and implant dentistry. So first, let me introduce myself. I trained in Birmingham. I did my BDS back and qualified in 2001, followed by my membership at the Royal College. And then I was on the third cohort of the DIPIMP Dent when it was very new at the Royal College of Surgeons. When we did that and the advanced certificate, followed by a master's degree in implant dentistry at the University of Leeds, which was a lot of fun. And my research project was on immediate placements in the aesthetic zone. So my current work I work in an implant center that I've owned for about 15 years, and my work is exclusively to do with implants or anything around implant dentistry. So I always find the topic of occlusion quite an interesting one, and something that can come and bite you. And when you've done quite a few implants, you can realize that why things go wrong of identifying issues in occlusion. So really, this was kind of written a way of going through the basics of occlusion and then relating it to dental implants and how they work. So essentially the topics is the terminology, and I'll just go and recap on that, to identify the muscles of mastication on your patients and what's relevant and when they're pathological or they're overused, how we would examine the temporomandibular joint, again for any abnormalities, and when they're relevant and when they're not relevant, what you actually need to record for implant dentistry and your implant patients when you're examining and doing a full case assessment, what you need to record and identify. And I think the really important bit is actually identifying parafunctional signs with your patients and symptoms, and kind of knowing cause and effect. So a lot of my work is immediate placement of implants, and you see patients who don't have, they have good diets, they don't have particularly high levels of caries in my area, but they are working longer, they're more stressed, especially with the lockdown, they're cracking teeth. So this is from clenching or grinding. So we're going to have a look at some cases and some patient photos of relating to that, really to avoid the pitfalls of restoring implants and having trouble later on. We're then going to look at some complex restorations and see how we can restore them. We're going to look at the slides and movements and excursions, how we record articulation of our patients and the movement of the mandible, and look at the accepted guidelines. Now, there's lots of different theories of occlusion, and there's different schools of occlusion that go in. So, an hour is just going to scrape the surface and give you a basic understanding. By all means, I'm not advocating that all the theories that I'm talking about are accepted in all the different schools, because there's a lot of different ways to think about this stuff. So essentially, that's kind of what I'm going to cover in the lecture. And we're going to have a section which is like a Q&A section here, that's going to go through what your thoughts are on things and hopefully have a good discussion at the end. But the idea really is to get you guys thinking rather than kind of lecturing to you too much, and get you thinking about different aspects of your patients and improving your patient care and your patient records with regard to occlusion. Okay, so let's begin. When we look at the basic anatomy of occlusion, we have to go back down to the skull and the skull bases, and we understand that the condyle is present, which is an articular surface at the end of the mandible in the lower jaw, and that actually sits in the glenoid fossa, which is described as a concavity in the temporal bone at the root of the zygomatic arch, and it receives this condyle. It is the only joint in the body that actually has an intra-articular disc, as you know, and it will translate and does translatory movements. But the mandible makes it a little bit more complicated because it actually moves in several different three-dimensional directions. So when we look at it here, you'll see that you've got several muscles that are attached to the articular disc. And the first one is the lateral pterygoid, and that goes forward, and you can actually palpate that intraorally. And I'm going to show you a slide on how to do that, because sometimes your patients will have tenderness in that particular muscle, which is quite indicative of kind of parafunction when you have patients with potential bruxism. There you see the mandibular fossa and the articular disc there. Now, one thing that I do, I'm mostly digital now with Trios, but a lot of the new digital platforms for planning and things like that are having digital articulators that will record that. And something that was a development by 3Shape recently, which was very cool, was actually to record the mandibular movements on excursion and incorporate that when you're sending it to the lab. So they're actually recording real-time movements of the jaw, so the laboratory can make more fluid restorations that will go with the movement, and not only looking at kind of the stamp position of the teeth coming together, but also how the jaw articulates and moves. So that was really exciting for me actually when they did that, because then you don't have to get your face bow out and things like that. But face bows and average value articulators are very useful kind of tools that we use quite a lot, and especially with full mouth rehabs, and the more information that you can give the laboratory, the better it is. So this is your temporomandibular joint, and the first thing we need to do is really be able to examine it and identify any pathology or any abnormal movements that would occur in this particular joint. Very rarely you get patients who have arthritis, and they might have arthritis actually affecting this joint itself, and then obviously appropriate referral will be required if that was the case. So that's kind of the first bit of anatomy that you need to know of the determinants of what brings your teeth together, or brings your patient's teeth together rather, and take it from there. So understanding about the temporomandibular joint. Okay, so angles classes. So a bit of orthodontic rehab. You've got skeletal bases and angles classes. So why is this important to us, and why is it important to implant dentistry as a whole? Well, it is quite important, especially I have a lecture on guided surgery that I do, and you have several different angles of the maxilla in relation to the lower teeth. Now, in the angles classes in relation to the cingulum plateau, if you're considering an anterior implant placement, everyone is raving about screw retention, anterior screw retention, and they might be placing the implants a little bit more palatal than before because they want to get that screw channel in. There's two dangers that if you have, a effective class 2 div 1 with or deep class 2 in itself, if you place that implant too palatally or plan it too palatally, your lower anteriors could be hitting at the point that the head is coming out, depending on the implant system. So it's important to understand how you would plan your placement of your implant in relation to the lower anterior teeth when they come together. So that's where actually occlusion is quite relevant. And if you do not plan this, you can get yourself in trouble, because you can have someone with a deep class 2 and a very retruded maxilla, and you've placed your implant way too palatal at a very high angle, and then you're into dynamic abutments and all sorts of fancy stuff to try to restore it. And you might end up with a restoration that comes out at quite an angle with quite a ridge overlap, etc., which won't be cleansable. So it's important to be able to assess your patients radiographically. I have my own CBCT scanner that I like to look at my patients radiographically and look at the relationship between the upper and lower teeth and look at the skeletal bases. So it's really something that we ought to think about a little bit more, okay, with regard to that. So, we try to achieve screw retention wherever possible, but sometimes it's not. And sometimes you have to use excessive angles and you have to use angulated abutments. And the big debate of screw versus cement retained in the anterior maxilla still remains. I still have long-term cases that have been there for 15 years plus, which are cement retained, which have no problem. The main thing I have the issue with cement retained is labs putting the junction too deep down into the tissues. So if you have thick biotype, you place your implant quite deep, and they put their margins even deeper. You're not removing that cement, and you're going to get cementitis and repeated problems. So that's the main kind of issues around this. So it's thinking about this, thinking about your planning, thinking about where your prosthetic envelope is going to be and the angle of the maxilla, i.e. the skeletal bases without the teeth. That's quite important when it comes to getting the occlusion right and getting the forces through that implant the most axial as possible. That's through the middle of the implant, the most possible when you do it. Okay, so we're going to then move on to the next slide. So what really we have to think about is, what determines occlusion? What is it? What is it in itself? Well, it's a balance. The way I think about it is it's in a balance, and every person's a little bit different on this balance. It's a balance between neurology of your patients, the musculoskeletal bases, or the muscles, the tension in the muscles, what the skeletal bases are, their anatomy. So everyone looks different. Everyone has different anatomy. They have different sizes of mandibles, different sizes of maxilla, different angulations of the maxilla. And lastly, one of the determinants is the dentition itself. Now, if you're controlling the dentition side of it, the balance of everything else have to adapt to slight changes. And it comes down to thinking about that, the adaptive capacity of your patients. Now, most patients can adapt and things jig around occlusion. Some patients have a low adaptive capacity, and even when that filling is slightly high, they'll really detect it. You know who I'm talking about, those patients who it's the slightest thing, you get your articulating paper out and it's still a slight contact and they're still thinking, it's not quite right. So that's a low adaptive capacity. And other patients, it's sky high. They go, yeah, that's fine, and they'll walk out, and they're absolutely fine. They'll adapt to it fairly quickly. So again, it's about that consciousness of that balance, and again, identifying that early on with your patients and seeing where it is. Now, the most important thing about the patients with low adaptive capacity is that you have records of their previous occlusion. So if you're changing something, you need to keep records of their existing occlusal patterns, because any changes, and that's caused any pathological changes or pain for them, you need to be able to go back to where it was. This is when you're taking a reformative approach to their occlusion. So we have to kind of make everything kind of reversible and try it out for a little bit through trial and error before kind of deciding on what we actually want to do with our patients and why we want to change the occlusion. And I'm going to talk really an interesting aspect of it is, sorry, I'm just going to go here. An interesting aspect is actually to look at the ways we can change our patients and the ways we can actually change this aspect about our patients and changing the bite altogether. And there's several different ways that we'll go through. So one thing that I will do in talk about is something called the proprioception test. Now, what I want you to do, there are quite a few delegates on here while you're at home, there's 92 people online now, right, is I want you all to basically go edge to edge with your teeth and press down as hard as you possibly can, them edge to edge like this, and feel your masseters. Just really press hard as you can and feel your masseters. And you will find that your masseters are not firing up, right? Now go back into your normal intercuspal position with all your teeth together and fire up your masseters again, and they're contracting, okay? Now that is a built-in protection, right, for your incisal edges and your front teeth. So what's happening there, believe it or not, it's really cool, is that when your edges are coming together of your front teeth, the PDLs are sending a signal to your brain saying, do not fire up the masseters because you're going to break these weaker teeth. But when you're hitting your molars, they're saying, right, let's go full power with your masseters and you can bite and crunch things. So that's evolution. That is how we are built. That is the protection that's built into you, built into your anatomy and built into your brain already to protect your dentition. Now, the proviso here is that in a class 3 skeletal relationship, they don't have that protection, right? So if they don't have that protection, they're much more likely to fire up those masseters and fire up those biting muscles and break your anterior restorations, or they're in a different occlusal relationship. So one of the things that you can assess with your patients is that if they keep on breaking that anterior composite, or they keep on breaking the crown, or they keep on de-cementing your implant crowns, or the screws are getting loose, the usual sort of things, is what was their skeletal relationship? And one thing that I see a lot of when, especially in my London clinic where we repair a lot of all-on-4 cases, is that a lot of patients, when they have alveolar ridge resorption, actually end up in a pseudo class 3 position. So they're restored back into this position, and they can fire up their masseters on all edges. So they don't have that proprioception, that protection built in. And especially important with implants, because guess what? There's no PDL. There's nothing to give you that feedback or give them that proprioception to not put excessive forces through it. So one of the major things we need to look at when assessing our patients is, where is our restoration? Can they fire up their masseters? Do the masseters have any pathology? Have they got any hypertrophy? Which we'll look at. Mesenteric hypertrophy is that you can assess that as your patients actually walk through your door, and you look at them and you think, you clench and you grind. And in fact, I'm just going to go way down to another slide, which has a really good example of mesenteric hypertrophy, which is here, right? So as you can see, huge masseter here, reduced on this side, right? Treated with simple Botox treatment, reducing the muscle size, but real clencher, stressed. This patient was a student, I think, and she was breaking her restorations left, right, and center. So this is where that proprioception test, that assessment of your patient and looking for these sort of signs in occlusion, is practical for the general dental practitioner. It's practical to look at and discuss with your patients, initially when you kind of start that. So that's basically a really, really important point. What I think is that looking at the proprioception test and looking at the feedback that you're getting from your patients, and looking at these sort of things, especially when you're dealing with an anterior cracked tooth or cracked teeth, you need to look at the causes, which may be and most likely are occlusally related, that are causing these problems. So often you'll get premolars that are cracked with large restorations, and you look at the initial contact slides are on that cuspal incline on that tooth that has caused it to crack right down the middle, and you're taking it out and putting an implant in. But if you don't treat the cause of that in the first place, that implant's going to be affected. So implants don't go suddenly with parafunctional bruxism or pathological occlusion. They go slowly, and they'll lose bone, or they'll have mechanical problems. And you want to avoid that. And one thing I'm going to tell you how to do is actually how to assess occlusion in implants, whether it's single teeth, advanced restorations, and through the experience of making mistakes myself, because we make mistakes, things go wrong, and you wonder, why has this happened? I've done everything right, the lab's done everything right. And often it boils down to, again, occlusal assessment, assessing your patients. So so that's a really important point overall that I'd like to make about doing that. And it's how I want to approach this particular lecture, is by making it as practical and useful as possible on a daily basis when you see your patients and when you're assessing your patients for dental implant treatment in the first place. And let's be honest, we do dental implants for failing dentition or missing teeth, or we treat the teeth if they're savable. That's the fundamental basics of this. So you're on a need to know basis. Right now, you don't need to know every single theory that's kind of going, but I'm going to go through a few of them. And one of the positions which is quite important to the edentulous patient is centric relation. Now, it's important because it's a reproducible position. It's a position that we can use when we're actually going to be restoring a patient with no teeth, or with one arch with no teeth, back into a correct position. So we need to give our patients and need to know where this centric relation position is. But in history, since 1929 to 2016, there have been over 31 definitions of this to make it even more complicated here, okay? The way to think about it is centric relation is the position of your mandible in relation to your maxilla, and it's defined by that anatomy that I talked about, the position of the condyles rather than the teeth, and it's a hinge position. So other definitions is the rear or uppermost kind of position of the condyle in where it sits in the glenoid fossa. So it is that a way of defining that itself where CR is. And if the patient can easily get back into that position and it's reproducible, sorry, then you can restore them to that position and make their teeth come together, and if it's comfortable. So there you go. So centric relation. So lots of definitions. Dawson did one, and we've gone round that hinge axis and the translatory movement. In realist terms, what I think, and that's just it's a personal opinion, and I've heard it before, is a position of comfort of your patient, restoring it over the years of forcing them back. If you're forcing your patients back into centric relationship and you don't 100% know it, because the only way to know it is either to actually visualize it or do ultrasound, is getting a position of your patient that's comfortable, that's reproducible. And whether that's the relationship between the mandible and the skull as it rotates around, or when it's in the most uppermost midmost position, it's not really as relevant, the definition, as the practical use of that actual centric relation in a day-to-day basis when you're doing restorations. And this might apply for you're doing dentures, but certainly with full arch implant dentistry work where we use balanced articulation and we try to get everything sort of gliding in group function, so forces are distributed evenly. We've got to get our patients into a comfortable position. You've got to be able to evaluate freeway space of your patients. You know, where's their rest lip position? Where are they going to be more comfortable? How much movement is there going to be in the mandible to hit the teeth that's comfortable for them? And the only way is a little bit of trial and error, right? A little bit of use of temporaries. I use a lot of temporary restorations. I see and make sure that my patients have an adaptive capacity. So that's, again, a practical use of understanding occlusion and understanding kind of how it works for these people. So centric relation, and that's really in the practical terms what that terminology would actually mean. Okay. So the conclusions really about this is that it's a reproducible position, and it's the most posterior and superior position of the condyle in the glenoid fossa. Whether we get it in that position or that, we don't know. But my position is a position of comfort for the patient. That's reproducible. So, and it's repeatable. That's the main thing. That the patient can keep on going into that same position. And that's orthopedically and musculoskeletally, because going back, we've got to always think about the balance. Yeah, the neurology, the musculoskeletal, the anatomical, that's there, and the dentition and the adaptive capability of your patients when it comes to occlusion itself. Okay. So how do we get it? How do we get that relationship with your patients? And you can see that this is taken from a journal in Journal of Oral Rehabilitation 2001. And by opening your patient's mouth, manipulating them sideways and just trying to relax their jaw. I mean, the worst place to relax your patients is in the dental chair with the nervous patient. But, you know, a lot of your patients will be, certainly what I get is, can you just open your mouth and then posture? They'll posture forward like this. And you're like, no, take it on your back teeth, just relax. And suddenly you'll place your hand here and you'll feel that mandible just click backwards. And you go, there you go, that's it. And your patients will laugh after that because they're not even conscious that they're posturing their jaw forward. So you're trying to get this reproducible position, but you've got to get your patients relaxed to get into that position. You've got to identify when they're posturing that mandible forward, because often they do it unconsciously. So again, part of the assessment of your patient and looking at centric relation when it's relevant, when you're restoring that jaw. And especially when you get denture wearers or people with failing dentitions or perio who have no ICP, you've got to initially assess that and record it, record that CR was attempted to be record the degree of freeway space that they have. Is there any signs of the parafunction, or is the TMJ when it's opening closing quite stiff? Any pathology in the TMJ, any stiffness or tenderness in the lateral pterygoid muscle, that may affect actually going into a more comfortable position. So you could have your patients actually spending quite a lot of money on having a full mouth rehabilitation on implants on one jaw, and suddenly they're just saying, well, I'm getting pain, it doesn't feel right, and you have to go back in, take everything off, and maybe go back to a temporary. So you want to avoid that. Again, my absolute is use temporary restorations, use temporary prostheses to adapt your patients first before going to final, before you're doing all your beautiful ceramic work and porcelain work. Make sure that they are comfortable with where you've restored them. And I think that's a really good and sensible point. So it's useful for the edentulous arches, obviously the loss of posterior support. So the patients who have anterior teeth and they've got no back teeth at all, and there's no effective bite to register, because if you think about it, you take a set of impressions, even if you're taking traditional impressions, you've got no back teeth. How are they going to articulate those models? They're just going to be all over the shop. They're going to move. You've got to record that, and you've got to be able to record that in such a position that you're again reproducing them back into the position of comfort, a position that is suitable for their face, which gives them balance, and you're balancing out all those different elements of their musculoskeletal patterns, their neurology, and the brain impulses that are kind of occurring. When there's a need for change, you've got to find it, and any pathological treatment. So, if there's a problem in the TMJ and you're trying to solve it, and they've got TMJ-DS and there's pathology going on, which is causing discomfort to your patients, you've got to identify which area of the occlusion you can play around with. And the easiest one is the dentition at first, and see where that parafunction is occurring. Let's stop that. Let's try that out at first instance. Then you go on to the other, the medical intervention using Botox and reducing bite forces and things like that. But the first thing is, looking at why they're going wrong, where their guidances are they anteriorly guiding? Is there interferences in the bite? What's their skeletal pattern before even placing implants? This is a crucial thing. Another really important thing that's popped into my mind was actually, when you are assessing your patients for a missing tooth, looking at the interarch space and recording it is an absolute prerequisite, because you could effectively have an upper six missing, the patient bites down, is overruption or deep overbite, and there's not enough space to restore a tooth because there's overruption of the opposing tooth. So one of the things that on our assessment forms that we do is we look at the interarch clearance between the maxilla and the mandible and make sure that there's enough space for your restoration to go in. So you've got to consider that, or you're just prepping these things down, which then brings us on to the topic of Dahl, which I think I've got some slides on later, which I'll explain. So a good friend of mine, Tiv Qureshi, does a lot of work on Dahl and composites, but I think it's a great concept that works very, very well for our patients. So the truth is, really, does it really exist? It's not centric relation, it's not a static position. It's a comfort position that is reproducible, and it sometimes changes in time because your patients age and they get older, and that position will actually change. Again, lots of different definitions of it. I'm not going to get into the debate of what it is because it's more relevant to the GDP. I'm just trying to make it as practical as possible, this talk, on what we're the subject that we're talking about. So the other area that you might hear in the world of occlusion is centric occlusion. So centric occlusion. Now this is a referral to the relationship of the mandible to the maxilla when the teeth are in maximum occlusal contact, irrespective, and this is the important bit of the definition, of where the condyle or disc assemblies are. Okay, Dawson said that. So some people call it intercuspal position or maximal intercuspal position, but basically we're calling it centric occlusion, and that's your ICP, intercuspal position, and that sometimes I'll refer it to. Simple definition, that's where you're going to put your patients, and sometimes the centric relationship will equal the centric occlusion. And sometimes in your patients, they will not. So if you get someone with a perfect class 1, their centric occlusion is slightly different to their centric relationship. But in restored dentition, they can be equal, which is also fine. So what do they talk about the ideal occlusion? I mean, this slide, it's right and wrong, because is there any ideal occlusion? I don't think there is. But what they're saying is that in implant dentistry, immediate and continued posterior disclusion on all excursive movements. I mean, I can't even say it. It's ridiculous. So basically, it means that moment your jaw moves forwards, backwards, left or right, that basically all your teeth don't hit at the same time. Yeah. So if you get canine riding, so I'm canine guided, so canine guided, everything else is not touching. Go that side, everything else is not touching. So that's basically that there's no interferences, everything's healthy, nothing's getting hit. So canine rise is the anterior guidance by the canine, and your condyles rotating and translating freely without the contact of your posterior dentition. So if you've got a patient with a big over eruption, they'll go halfway and they go, oh, my back tooth hits just there, and that's an interference. Do you need to get rid of it? Well, you might do if you're restoring around there, or you might not. So it really depends on where you are with your patients and their adaptive capacity. And is that interference causing a problem to your patient? So again, asking yourself those questions, thinking about those different things will help you along the journey. Okay. So evidence of the definition of parafunction that has been around for a long time, and it's hidden. So long centric, let's talk about this, is a concept to give some freedom of the occlusal architecture. If there is an ideal occlusion, why do we need this long centric? And a custom incisal guidance table. They're used for full mouth rehabs where there's evidence of a specific envelope of parafunction. So what these were, so years ago, we used to use, well, not years ago, we used to use articulators quite a lot. And you'd ask your technician on a set of study models, you get them articulated with a semi-adjustable articulator. They get a tiny bit of Duralay, and they'll put it on the pin, and they'll run the pin through it as they're guiding the mandible forward, backward, left, and right, and they keep it to the side. And that's a record of your guidance table. That means that whatever restoration that they do, they've got the guidance what it was before. If you've done the full rehab, you haven't done that, and your patient has, and very few will, but your patient then cannot adapt to your new occlusion as either breaking restorations, finding uncomfortable, getting pathology, and you cannot then take them back to the same guidance as you were before. So now, again, the importance of keeping records of your patients, especially when you're doing irreversible occlusal changes or changes that you've made and you can't go back to where they were. This is really important. You have to keep a record of how your patients moved along. So again, in the advent of the digital world now, it's really cool because now using various different intraoral scans, we're able to actually record the movements of the mandible, the maxilla, and how the teeth were initially by a simple intraoral scan, which now takes minutes to do as opposed to hours. So all of this is great, but what do we need to record? What do we need to medico-legally record for our patients to make sure that, everything is down? Well, technically, you need, on implant cases, a set of study models, which could be digital. You need a face bow and a diagnostic wax up of your final tooth. These need to be articulated. You need to record the guidances of your patients. So you need to look if they're canine or their group function, which particular teeth they're functioning on when they're going left to right. Are there any, you've got to ask yourself, are there any working side or non-working side interferences? What's their angles class? What's their orthodontic class? You've got to record that. So you've also got to record tooth surface loss, things like abfraction lesions. You've got to be able to identify that. Is there signs of wear and tear? Is there signs of parafunction? We are clinicians and we are physicians of the mouth that need to look at those small little tiny signs on your patients that put little alarm bells. Right, this is occlusion. This is an occlusal issue. And this doesn't only mean to implant dentistry, it means to general dentistry as well. I mean, you really got to look at that. So you need to look at the TMJ, ask them to open and close, feel it, palpate it, look for any pops or creaks or anything going on. And when they're opening or going to one side, there's an issue there. And fraction lesions are a big giveaway of parafunction. Yeah. So there's signs of parafunction that you've got to look at, and you've got to make sure that you note, identify, try to prevent, discuss it with your patient, discuss why these things have occurred, and take the time to educate your patients and decide with your patients. So you do a co-diagnosis to conform or reorganize the occlusion. And you say, Mr. Jones, look, you're breaking X, Y, and Z teeth. This tooth is going to need an implant. But hey, look, before we jump in and put the implant in, why don't we identify what caused this and do some preventative work on your bite before we actually place your final implant restoration? Because what you don't want is, you don't want to break other teeth, and you don't want to have this. And he'll say, and 9 times out of 10, the patients will turn around and say, yeah, that's absolutely fine. I really like the idea of that. So I'm just going to have a sip of water. So identifying the key areas of occlusion and treatment as required. And a soft guard usually does the job, to be fair, but there's lots of different guards, and we can go through those as well. So please do record your patient's occlusal patterns, and record this and identify it. So it's an absolute prerequisite, because if you're doing implants and you've missed something that's caused this, and subsequently years down the line that has caused problems with your implants repeatedly, and God forbid you end up in front of the GDC, or you end up in front of justifying yourself to a solicitor, you will have to produce those records, and they will, expert witnesses will look at it and think, right, how did you, it's an occlusal issue, the implant restoration is broken, the screws loosened, has the occlusion changed, was the occlusion initially assessed? They go back, right? And unfortunately, we are very, very closely assessed by fairly unfairly, mostly by expert witnesses on things, and we need to be able to show our methodological thinking about occlusion and how we've approached kind of the subject and what we've done. Now, if your patient doesn't wear the guard, there's nothing you can do. If your patient doesn't adapt to it, there's not a lot they can do, as long as you've done your due diligence. And that's really important here. Do your due diligence before you're placing your implants. So how do we assess TMJ health? Now, this is an interesting area. Crude methods include, does it pop? Does it click? Does it lock? Assessment of the deviations on opening or closing of the pathways. You can get a stethoscope out if you're fancy, if you've got one in your drawer, Doppler ultrasound if you're even fancier, and radiography if you also want, and you can interpret that. Previously, there used to be things like jaw trackers. They can track the jaw movements like this, and the famous JFAT scan, which is also good, because it's kind of like this digital articulating paper that tells you your timing and intensity of the tooth contacts. And in fact, on our occlusal day, when I was running this as a course, we had the T-scan in to show it. It's a fantastic bit of kit, and it's lovely because it shows you how much intensity that the force is going through. Okay. So this was an interesting point in an article that I read, that 10 to 15% of the population showed disc displacement with perfectly normal function. So they're displacing these and they're showing the clicks and they're just functioning normally. Giving them an array of exercises and things like that could be also quite a good thing. So I hope not boring you still, but I'm still awake, which is great. We're going to go on to looking at the differences between implants and natural teeth. Now, the main thing is, if you think about it, when we learned at university about ankylosis of a tooth, or when is effectively what an implant is, it's ankylosed to the bone. There's no periodontal ligament. A tooth actually is a lot more forgiving than an implant is. So a tooth can sit there with periodontal disease or PDL widening for years and years and years and be fine. An implant just tends to go very quickly with bone loss. Yeah. So as you can see, natural tooth, enamel, dentine, pulp, gum tissue, periodontal ligament. And an implant, no periodontal ligament, no proprioception at all. So there's a lack of proprioception on implants. You do not know how much force, or your patients do not know how much force they are applying through that implant. Yeah, they don't know that. So there's no periodontal shock absorption. Yeah. So that's an important thing, especially with patients who are already parafunctioning. So in the case of occlusal trauma, mobility can develop in a tooth But when it develops in an implant, it's probably a bit more serious than what it is in a tooth. And you can recover a tooth because the PDL can recover. So you can take away the interference and the tooth can firm up again, right? So you can't get that response in an implant. Usually when the implant is loose, there's fibrous encapsulation that's occurred, and that's it, game over. You know, it's that implant's coming out and you're going to be replacing it with a tooth. It's a bit more forgiving. So natural teeth are associated with high occlusal awareness, proprioception about 20 micrometers. But I don't know what that means, but it's relevant somewhere in the world. So, you know, having a tooth in is a good thing when it comes to proprioception, and actually forces through your teeth. Okay. So you need to assess things like, you need an articulating paper. Like if you have a really thick articulating paper, it's pretty useless. So you have a nice thin one. Centric occlusion under light tapping forces, ask your patients to tap their teeth together. An implant should exhibit light axial contact and avoid parafunctional slides. In real terms, where I assess, and this is important, when I fit a single tooth implant restoration and I want to assess the occlusion, I'll ask my patients to chew. So I want you to do this tomorrow. Whatever you learn from this lecture, if you take one thing away, take this. When you're fitting that final crown, ask your patients to bite together and tap their teeth together and use the color red articulating paper. Then ask your patients to chew and use the blue side. Now, chewing will completely give you new contacts compared to asking them to bite up and down. So you've got to ask yourself, and the reason I'm challenging your mind on this is, on a day-to-day basis, when patients are chewing or eating or bringing their teeth together, they're not tapping them together when they eat. They are chewing. And chewing, my friends, is the way you assess occlusion on an implant crown. If they're chewing, then you can understand where they're going to majority put that force through that implant crown. I had a recent student of mine come to me with saying, you know, Avik, this crown's loosened several times. You know, what's going on? I don't understand it. Should I use a new abutment? Should I use a new screw? I said, well, it happens. Have you looked at the occlusion? Have you looked at the chewing forces of your patients? Is your patient bruxing? Because everyone, and I bet everyone of the 100 people also on this seminar is going to be thinking the same when they say this. Because Mr. Jones comes in with his implant in his hand and goes, I was just having a tuna sandwich, right? Who's heard that? I bet a lot of people have heard that. So I wish I had an audience to speak to, but it's funny to me. I'm just laughing for you. But it's always something like a soft sandwich. I wasn't doing anything. I de-cemented this and I wasn't doing anything else. No, patients might tell fibs. Patients chew, they eat, they forget, they're human, right? So if you say soft diet to somebody, what's soft to somebody is not soft to somebody else. So, you know, to think about it in that kind of manner is quite important, quite important. Okay. So moving on, what we're going to look at is a couple of little cases before we come to a conclusion, because we've been going for about 47 odd minutes now. So canine or group function, which is better with occlusion? Well, it depends. It depends on how many restorations there are. It depends on if you're doing a full arch on implants, it's balanced articulation. That means effectively like a group function. It's canine guidance if your patients are canine guidable, right? And you think it's advantageous to change them, you can try. Composite's a great material to try things out because you can bond it, you can make things into canine guidance and see if they adapt. Another useful thing I want to talk about is the dial mechanism. So what I want to do here now is have a little bit of Q&A time, if that's okay, Guy, and show the audience a patient who came to see me for a broken upper left four. So this was my patient and his upper left four was broken. And I want to kind of put a Q&A up and say, what are the things based on what we've talked about now that you're seeing when we're seeing, number one, the patient, when we've come in, and we'll call this Mr. Jones for argument's sake. And in Mr. Jones's dentition, we have a set of clinical photographs. We have the identified broken tooth. But what else are we seeing in this picture is the question that I'm putting out there. What else are you seeing that may be telling you that this patient has some other occlusal issues? Let's put the Q&A up and see what kind of suggestions that we're kind of getting at the moment. Open questions. So it's more just suggestions, just brainstorming what people can see. Mesenteric hypertrophy, Malcolm Calvin. Thank you. Yes, absolutely. Yep, there's cusp fractures. Vivek has said possible abfractions due to parafunction. Yes, you can see that. Absolutely. You can see abfraction. Second slide on the right-hand side, you can see loads of abfraction going on. I agree totally with that. Due to parafunction, it's a given. Deep protruded arc closure. Yes, that's a good one. So we can say a deep class 2 skeletal bases as well that you're looking on there. Alan Pudden, I like that. So we're all thinking in the right way. We're seeing things like shiny amalgam surfaces occlusally. I like that one. That's, yes, he's polished them. Thickened alveolar bone. Oh, that's fine, but I'm not sure if I can see the alveolar bone, but you can see the ridges are quite thick, but yeah, absolutely. So it's really an abfraction worn canine tips. Yep, the canines are very flattened. That's another good sign. So these are all little signs that you can look for and approach this particular. And Viren has said abfraction and worn canine tips. Well done, Viren. Very clever chap. So basically, it's to get you thinking about your patients and get you thinking about, okay, there's a restoration and it's a broken upper left four. He's cracked that tooth. It's a deep cuspal inclines on this patient. So what I chose to do was perform something called dull on this patient. Now I'm going to just flip to the dull principle because this is quite useful on here. Is dull. Okay. Dull. Now, this is always fascinated me, was the dull principle. And I'm going to show you a case that I did. And now this was cement retained. It was done back in, when did I do this case? I did it in 2006, right? And it's 2021 and it's still there, right? It's pretty extreme. Sorry about the quality of the photos. I wasn't very good at photos back then, but anyway, what we did, bilateral sinus lifts, placed some implants at the back. They are tucked behind the canines. They're not into the canines, by the way, so they're fine. And we placed some lateral posterior. Massive, massive bruxis, this guy. I mean, he'd literally come into me and he goes, look at my teeth. I don't like them. They were tombstones that he'd ground down. And he was very class 3. So again, looking at principles of the protection of the incisal edges when they come together, he had none of that, right? So we crown lengthened at the front teeth, right? As you can see, put some restorations in, jacked him up, increased his vertical dimension, but we followed the principle of dull. We followed the principle of giving him the posterior support and giving him the implants at the back, but we worked in harmony with his dentition. And he was very class 3, prognathic mandible. And we used that with a combination of a splint, and we warned him, and we kept this going, this restoration going. I mean, now, if you're talking 2006, 14, 15 years on, it's stable, you know. It doesn't look as great as it did 15 years ago, but he's not broken anything, you know. He's not broken the teeth, and just shows that putting the principles are done. Now, for example, a simple case of when we actually looked at going back into this case that we looked at, of adding a little bit of composite on the canines and jacking them up, and it has to be greater than 3 millimeters. You've got to disclude the posteriors by greater than 3 millimeters, because that's when the brain forgets. If it's less than 3, what it basically means is that the patients are going to want to find their old ICP and they'll find it uncomfortable. If it's opened enough, and you've got to tell them it's going to be uncomfortable, some will come back and say, just take this off, I haven't adapted to it. Others you'll find will adapt to it. And suddenly what happens is that everything jigs around of the balance of the neurology, this musculoskeletal system, everything jigs around, and those back teeth meet, and you've opened the front bite and you've changed the guidances. And that was the principle of Dahl. Now, before composites were brought in, when Dahl originally did it in the 1960s, it was done by chrome dentures or chrome overdentures that would sit on the lower anterior teeth to change their guidances on there. So a really, really useful kind of one. So really with the examination here, I use a lot of shim stock. I'm going to conclude my lecture now because we're coming up to the 1 hour mark, and shim stock's very useful to looking at holding contacts when you're actually looking each side, and you're fitting a crown, to take shim stock contacts of the opposing side if you've changed anything. the different types of articulating paper that are out there. But as I said, using different colors and using the thin ones are good. Look at things like over-eruption of your patients, and are they over-erupting in the interarch space? We've talked about that. We've talked about mesenteric hypertrophy, the arc of closure of patients. And we're going to talk a little bit about parafunction in patients like this. So this patient is a very low adaptive capability. And we're going to talk about the HV or VH slides, right? So that's a long horizontal slide. So if you're all fully dentate and you go and you curl your tongue back, and your first point of contact will be on the posterior part of your premolars, on the cuspal inclines, and then your jaw will slide slightly forward. So I'm doing it at the same time, slightly forward. And that's basically a normal situation, right? Which is 1.5 milli posterior to superior for the first contact of your mandible coming vertically upwards like that. Now, if they've got a long horizontal slide, that means they're like this chap here. And they means that whenever you put your lovely crown on with lots of cuspal anatomy and things like that, they'll not adapt at all. They'll say, no, and you'll be grinding it. And you often find you'll be grinding it down, especially in the premolar area. And you're thinking, I've taken a load off and it's still high. He still finds it high. He's still hitting it. It's because that they are literally healing on that particular tooth, on their occlusion. So just thinking about how they are and how you're going to restore them, because you have to ideally conform to their movements. So if you're restoring the 5 and 6, I'm not going to do another Q&A because we're coming into our main Q&A, but you're restoring the 5 and 6 here. You've got a lack of posterior support. You've got a patient with fairly bad oral hygiene as well. So there's a lot of things kind of going on with this patient, but it's about to see those sort of things in your patients and identify them and identify how you're going to approach those particular issues, which is quite important. Something as well you need to think about is a shortened dental arch. Often with my students, when we talk about implant cases, the patient wants a single implant here, but it hasn't got 5 to 5. You've got to get a 5 to 5 shortened dental arch. It's a minimum number of teeth in occlusion, which means it's 1 to 5 teeth in a row either side. It doesn't mean they've got a lower 7 that's biting and they've got 4 to 4 at the front and that counts as 5 to 5. It doesn't. It's 5 teeth in a row. So 10 teeth at the top, central to second premolar, and they have to be in occlusion. And that's been proven in the literature. So you've got to follow that rule and tell your patients, well, you don't need 1 implant. You'll need actually 2 or 3 to make up your 5 to 5 arch. If you do 1 implant and they don't have a 5 to 5 shortened dental arch as a minimum number of teeth, you will open yourself up to being questioned about, did you have adequate posterior support? Did your patient have adequate distribution of those forces to be able to kind of do that? You've got to think about things like biomechanics, a denture opposing fixed restoration, cobalt chrome denture opposing an implant. Is that going to work? Is your implant going to break that denture? Often you do lower anterior 2 to 2 bridge on implants. They've got an upper acrylic. They're going to break their acrylic. Your implant's stronger. Implant retained denture opposing a natural dentition. Usually a lot of trouble, because if you, especially in the lower mandible, you've got 2 there, you've got movable parts. I'm not a massive fan of overdentures on implants, to be honest. I've never really got on with doing them for patients because, they are movable parts and they wear down every 2 to 3 years. Who wins? Does it work? Will it work? We don't know. It's kind of a little bit of touch and go because every human is different. You can't apply every theory, every paper, every piece of evidence to every single. We can only do our best for our patients and say, given the presented evidence that's there over X amount of years of doing implants, this is what I think we should do. And you have to co-diagnose with the patients and you have to discuss the risks and the benefits and the alternatives to get adequate consent, because now we know consent is a process. It's a process of understanding, educating your patients, working with your patients, and doing and documenting for, whatever you do, document all of these things and all of the discussions that you've had, because it's a great thing to do. So really, we are coming to a conclusion now that mutually protected occlusion with anterior guidance, evenly distributed compact, wide freedom of centric relation. I hope you all understand that now. Occlusal overload, including you must reduce cantilevers. Not a fan of cantilevers. Not a fan. I'm not a fan of using one implant and trying to do cantilever forces because you're creating torsion, you know. Again, can you prove what your patients are eating, how they're chewing? You know, yeah, it'll be fine because it's a premolar. I've got another premolar. I haven't got space for 2 implants. So I'll put one in and cantilever it forward. And then lo and behold, it's de-cementing and the screws are coming loose. And you've got to deal with those complications. Do you need a headache? Think about it. Increase the number of implants. Monitor those parafunctional habits. Keep on reinforcing that you're monitoring. Narrowing the occlusal table, decreasing your cuspal inclines, progressive loading on patients with poorer bone quality if you're increasing the bone quality around there. And you want to protect that implant. The peri-implant bone requires an understanding of how occlusion plays on influencing. So one thing we know, I do a lot of immediate loading, is that if you load an implant immediately with light occlusive forces, and I wouldn't do it on a bruxist, then the density of bone around the implant increases, and it's actually quite good for it. But if they overload it, it will cause mobility, and that implant will not osseointegrate. So that increases your chances of failure. So again, assessment of your occlusion of your patients is vital when it comes to those sort of things. So I think for now, I've covered as much as I possibly can. The main thing, a little party never killed anyone, but know your limits. If you're in doubt and you are not experienced in the restoration and it is an extreme wear case, you can send it to a more experienced GDP or a prosthodontist or a restorative specialist. But normally, luckily, a majority of patients are in a high adaptive capability. So normally just crack on and then, just keep good records and work in the normal envelope of occlusion most of the time. So, thank you very much. And that is all, folks. I hope you enjoyed that lecture, and it's been an absolute pleasure giving it to you. You can all contact me at avikd@mac.com if you have any questions at all. But we're going to enter the Q&A, I believe. Funny, because it's mainly the ones that have sudden bone loss. And it's actually, would I do something differently? Probably not. In the sense of they changed, not me, because the patients changed their habits or their stress levels went up. And for example, I did a full arch, and it was, I think there were 8 implants that I placed. And the patient came back, it was in London, came back to London, and he'd left the country for about, I don't know, it was about 6 or 7 years. He left the country, he came back, and he goes, "This is loose," right? And I said, I looked at it, and it was just 4 implants just came out in his hand, right? And I said, "Wow, why did this happen?" And I repaired it. That wasn't a problem. Why did it happen? The implant placements were great. And this was like, it'd been in function a long time, but that always stood out with me. Like, what on earth? This is not a smoker. He's fit and healthy, this, that, and the other. So found out that he'd gone through bereavement, death, he'd had cancer, and all these things of stress. And his masses, he looked different as well because his masses were out here. And how that change of habit suddenly affected his full arch, So we kind of worked back on things, but that was the story I really probably have to share. But luckily, touch wood, that hasn't happened too often, so it's all good. Yeah. So bone loss issue, absolutely. So bone loss issues around occlusion, around implants, there is no given definition. It is technically peri-implantitis. To make the diagnosis is the presence of pus, inflammation, and bone loss on your implant. Yeah. So if you're seeing an unusual pattern of bone loss, but no pus or inflammation, and good oral hygiene on your patients, then yes, it's an occlusal cause of bone loss, and you just define it as moderate horizontal bone loss due to occlusal patterns. Is it treatable? Probably yes. What you'd have to do is you could remake the crown by all means, but it could be a simple thing of looking at the excursions, looking at the interferences, asking your patients to chew, seeing what they're doing, trying to treat that first and seeing if it stops. You see, the major difference, and I think I made this in the lecture, was that teeth recover. They can go loose and then they can recover and you can gain some bone back. Implants don't. When the bone's gone, it's gone. Right. And that's you can only manage that by keeping those peri-implant tissues healthy, if they're pink and healthy, and making sure that, if there are any implant threads exposed, that they're not plaque retentive, because you don't want that to become peri-implantitis. But there isn't no set definition of actually bone loss solely due to an occlusal issue on implants being defined as anything at this moment, as far as I know. Somebody else might come up with something, but there you go. Do you conform with the skeletal pattern? That's a good question, actually. If you notice, most people will try to go to a class 1. Okay. Do I want to go to a class 1? Most of the time, yes. But if it causes a massive ridge overlap, I'm not going to, right? Then you would have to conform. You've got to make that informed decision. I don't do a lot of all on four. All on four is famous for cutting down. It's a commercial concept. I've always said this in my lectures, right? It is a concept that, don't get me wrong, there's a load of evidence it works. I'm absolutely fine with that it does, but it was invented by a company, and I just don't like the fact that you're cutting away good alveolar bone, which is precious, and you're taking this out to create a transition line to accommodate a prosthesis that looks nice. But what happens in X amount of years when those fail and you've got to replace them, and that alveolar has already been chopped down? Where are you going to gain more bone from? Alveolar bone is what we're trying to rebuild. So I mostly can conform, but I won't do anything, again, just trying them. When you're doing, you do all on 6. So I do 6 implants as a minimum. I won't do all on 4 very often. But if you're putting those implants in, you've got to use a temporary prosthesis to try to train your patients into the bite to make sure that they're comfortable, right? He says, for example, a class 3 skeletal, will you aim to maybe an edge-to-edge bite or reverse overjet, or will you try to get them into a class 1 relationship with retrocline lower incisors, for example? You could retrocline them, but sometimes they won't adapt to that. Or sometimes, again, you've got to look at the ridge, the degree of ridge overlap. How much are you pushing these teeth forward to, if you've got a maxilla here, for example, sorry, you can see it, maxilla here, and you want your teeth out here, that's a problem. You're going to have this massive, it's going to feel bulky. People go palatal. So you've got to think about, working with your patients, discuss that with your patients, and make a decision based on the discussion with your patient and what you feel is best. Do you always aim for class 1? No, you don't have to always aim for class 1. Is there any right or wrong answer to your question? There is none. So there you go. Mesenteric Botox. So you place it, and within about 3 months, the masseter will reduce, and it will stop firing up in 3 days. So the force of bite will reduce in 3 days, but the actual bulk of it. So a lot of aesthetic practitioners will use Botox in the masseter to reduce and slimmer face. But the clenching habit and the clenching forces are reduced pretty quickly, actually, pretty quickly. Yes, Hassan, it's about talking about the bite. So you've got to firstly present to your patients. This is what I say. I said, you have broken this tooth because there is a slight issue with your bite, because your teeth should only be coming together when you swallow. So if everyone swallows, their teeth come together. And when you're chewing food, that's when your teeth come together. If any point outside that your teeth are come together, it's known as parafunction. So sitting down and educating your patients about the human bite and telling them that, look, if we address the cause, and this is the key one, Hassan, that'll answer your question on how you talk to patients about it, is say, if I could do some simple things with your bite to prevent you breaking other teeth and not needing other implants or other restorations, would you like to know about that? Because that's really quite an important aspect of looking at the cause of why this has happened and preventing it happening in the future. So if you say that, then you'll find your patients are much more receptive to listening about the bite and using very simple terms. You don't have to go into, complicated occlusal anatomy. You speak in layman's terms, in the sense that you say how your teeth move when you're gliding them over each other forward and backward, how they're going left and right. Are you feeling some of your teeth hitting other teeth? So you can put it in really simple terms to people. And then I think that will make it a lot more understandable for them to get much more out of that conversation that they're having with you, which I believe that you have to do anyway as part of that. I think that's a very good question again, Matt, because I think the literature changes. Yeah. The fact is, the way the literature says that in between implants is 3 millimeters, in between teeth is 1.5 millimeters. Okay. So you can creep up closer to teeth. Now, one of the questions that we had in one of the academy exams that we did was why is it? Why can we get closer to a tooth? Because the simple answer to that is because the tooth has a blood supply, it has a PDL. If you put 2 implants too close together, you get necrosis of bone, because the blood supply, effectively the capillary blood supply, depending on, again, so many factors here, So I think the literature is quite generalized on this. So have I creeped closer to 1.5 than a tooth? Hell yes. Have I put implants closer than 3 millimeters? Hell yes. Have they failed? Hell no. Right? They haven't. So it works. You can get them close, because everything, guys, you got to think about, and girls, sorry, is in 3 dimensions. It's a cylinder next to another cylinder with a degree of bone in between. Now, the degree of bone depends on the effective blood supply. Yeah. The papers and the general rules are that, this is where the limits lie, but it's still averaged out. If you have very, very D1 bone, for example, there's going to be very little blood supply, and you put implants close together, you're going to get necrosis. Yeah. It doesn't mean that you can't bend the rules. And is it totally wrong? No. But, it shows that you're thinking about these sort of things. Yes, you can do cantilevers if you have insufficient space, if you're measuring them exactly, but aren't there thinner implants that you could use? 3 millimeters, 2 millimeters. I don't really need to use cantilever. I haven't really used a lot of cantilevers in my career, and I've probably placed now probably in excess of 5,000 implants. But there will always come that dilemma that, if it's a lower anterior and the patient has a perfect dentition, no signs of parafunction, things like that, put one in and replace 2 lower small incisors. Possible. That I don't see that being a major problem. It's when I see people who've done, big premolars. Premolars a big one, because premolars won't have enough space. You put one in, you cantilever another premolar. You haven't identified that these are key teeth on the bite, and hey presto, you're going to have problems. So identifying and that comes down to your assessment of occlusions. Okay. That's a very, very difficult question to answer, because I don't know where the teeth are and where your implants are. So it's kind of one of those things. Implants should have light occlusal forces regardless. They should be taking load. Once again, it comes back to, you're again thinking in terms of how are you assessing your patients? You're looking at chew forces. If it's just in intercuspal or just tapping forces and your implant's a bit lighter, you can take an implant or a tooth right out of occlusion completely, right? So your patients are biting down and there's literally a gap, and that patient could still be chewing a boiled sweet, right? They're still going to be putting that force through that implant or through that tooth, aren't they? So that's where it comes down to, again, the power function. How would I manage it? I would definitely manage, if I'm doing some teeth, they're going to have the same sort of force distribution as the implants do, right? So I balance it when I do my restorations. Is that balance assessed in ICP or the intercuspal position? Probably yes, and chewing position. But it's going to be very hard for you to then reduce the forces on the implants, because to be honest, implants can take it all. But again, I would balance them between the both, and I'll bend the rules slightly on that. Okay. In general, that I would go for a soft splint on a full arch restoration on my patients. Most of my full arch restorations are made from a ceramic material. I very rarely use acrylic, actually. But I go for soft splints. Why? I have no reason, because they just tend to work very well. They're replaceable. I think a lot of the different, I think I've got slides on splints, but we just didn't have time to go through. Here we go. Anterior deprogrammers, they won't work on implants. 8 millimeter limited headache pain, they won't work on implants. Wear facet splints, which are very hard, they're going to be difficult to put onto your restoration. If you're doing an acrylic hybrid with the bar, you don't want to put something more hard acrylic on it, because there's no need. So I just go for a soft one personally, and put a soft one that covers all the restorations. That's done. Thank you guys. Have a lovely evening. Thanks very much, Guy and the